The House Oversight Subcommittee on Public Health and Food Security will come to order. Would the clerk please take the attendance?
Chair Berrien.
Here.
Representatives Paquette.
Here.
Green. McDonald.
Here.
Cerniglu.
Here.
Mr. Chair, you have a quorum.
Representative Paquette moves to approve the minutes of the May 20th meeting. Hearing no objection, they are approved. Today we're going to begin with testimony from the Michigan Liquor Control Commission. This is a follow-up from our May 6th committee meeting that when we heard from the Office of the Auditor General on their reporting of the IT system. So I'd like to welcome from the Michigan Liquor Control Commission Chair Kristen Belzer, Business Manager Carrie Crone, and David Marvin, their IT specialist. I do a lot of things. Okay. Well, thank you for being here, David. So if you guys want to get started with your presentation, we're all ears.
Well, thank you so much. Again, I'm Kristen Belzer. I'm Chair of the Michigan Liquor Control Commission, and I am joined by Carrie Crone, who is our Business Manager, and David Marvin, who is our Executive Services Director. That's his official title. We appreciate the opportunity to be here. We are, we believe, doing great work for the state of Michigan and serving your constituencies, and available at any time to answer questions from not only you, but to have an opportunity to interact with your districts as well, and to educate on the policies and procedures of the Michigan Liquor Control Commission and ways for people to get into business and to be successful. This is the third committee that we've had an opportunity to do a presentation to. We always enjoy the opportunity to get in front of people and to talk about the work of the MLCC. On our processes, it is quite complex. It is a big operation, and as we will get into in just a moment, a big system that we not only are operating currently, but also trying to move into the 21st century with a new system. I want to thank Stone for his continued due diligence in working with our office to get today scheduled. It is an honor for us to be here and to share this presentation. I'm going to turn it over to Carrie Crone right now to just talk a little bit about the ins and outs of the MLCC and how we operate, and then dive a little bit into some of the other areas of operation for us, and maybe then open it up for some questions that you have. Carrie?
Thank you, Madam Chair. Good morning. We are pleased to be here. I also want to recognize our Director of Finance had a family emergency last night, so she was scheduled to be here with us and unfortunately could not make it. I want to do a shout out to her. I think she's probably watching all of us on video. I know she can't quite participate or answer questions that way, but we certainly can follow up with anything if needed in her absence. And I also want to thank Stone for working with us diligently to get a date that would work for all of us here. So we appreciate that. I'm going to go through a few slides to give you some history and just kind of an overview of the commission as well, to get you a little understanding of kind of what we do on a daily, weekly basis, and then also what our systems do to support that entity. So the Michigan Liquor Control Commission was created by the legislature in 1933 after Prohibition. So we celebrated a 90th anniversary just a couple years ago. We are under the Constitution controlled to empower the regulation of alcohol beverage traffic throughout the state. We are a Type 1 agency housed underneath LARA, the Department of Licensing and Regulatory Affairs. The mission of the Liquor Control Commission is to make alcohol beverages available for consumption while protecting the consumer and general public through regulation of those involved in the sale, distribution of alcoholic beverages. Just a little bit about kind of how we are set up as an organizational structure. So we have 5 commissioners. We have 3 of those commissioners are administrative, one being our chair, who's with us today, Chair Belzer. And then we have 2 hearing commissioners that work with all of our violation hearings. And we have myself as the business manager, and then we have 4 different divisions within MLCC, Executive Service Division, That's officially what David is the director of. He also is all things legislative and all things IT. So we have him here for both those purposes today, because if this system went down, I would not be the one to try and figure it out to bring it back up. So thank you, David. He also, you will see him at many of the other committees as he follows all of our legislation and works on those issues. Our licensing division, our enforcement division, and our financial management division. We also work with a specific grouping within the Attorney General's office. And then a little bit more about kind of how we operate or function. You've probably heard or familiar with the three-tier system. So those three tiers are the supplier tier, the wholesale tier, and the retail tier. Below those give you a little more in depth of what type of businesses or licensees fall within those tier structures. But importantly, I want to point out to you the number of licensees we have within those areas. We have over 1,200 manufacturers, over 100 wholesalers, and over 20,000 retail licensees throughout the state of Michigan.
Can I, so for my clarification, so is Michigan a control state then for spirits?
Yes.
So can you explain what that means so we better understand?
Sure. The control state structure basically is we are the wholesaler of spirit products. So any spirit product that is sold within the state is first purchased from the state of Michigan or through the MLCC. There are 17 other control states made up in the U.S. It is actually our structure in Michigan. We're not only a control state, but we are unique in the fact that we do not have our own state stores or our own state warehouses. So most of the other states, all the other states actually have some form or mixture of that. So if you've traveled outside of Michigan, you might have actually, if you wanted to purchase alcohol, you might have had to go into one of their typically referred to as an ABC store, an alcohol beverage store. In some states, you can purchase, or you have to purchase all your spirits, wine, and beer at one of those stores. In some states, it might be just the spirits, and the beer and wine might be sold through other distribution centers. In Michigan, as we all know, you can go to your local grocery store, your local party store, and purchase take-home products as well as within our on-premise license locations.
So if the state is the wholesaler, then
Correct.
is the ADA an agent of the state, or are they an agent of the manufacturer?
They are an authorized distribution agent for the state of Michigan for the delivery of the spirits.
Okay, thank you.
No, that's fine. Thank you. That's what we're here for, is to hopefully answer questions and maybe help understand how we operate. Our licensing division annually issues over 10,000 licenses and permits. They actually issue and renew those. Our annual renewal is April 30th of every year. We like to point that out because we are very proud of that. The other, in addition to this, that our licensing team and MLCC does is we issue 9,000 or a little over 9,000 special licenses. Those are the 24-hour event licenses that are throughout the state in many of your communities for those special festivals, and usually kind of a one-day or a couple-day event for a weekend. And that's in addition to those numbers. Importantly, I want to point out, since we are the wholesaler of the spirits, that we have over 14,000 retailers that can order spirits on a weekly basis. In comparison to other states and even other control states, that is quite a large number. Many of the other states operate in a different structure where they do not distribute directly to all those independent businesses. And in many cases, those businesses have to go to those stores that are either a wholesaler or store by the state to pick up their product. So in Michigan, our ADAs will deliver spirits to any given week up to that number if every licensee orders. Every licensee is able to order for free delivery 1 case minimum. in order to get that delivered from the ADA warehouse right directly to their business doorstep. We have over 4,800 off-premise retailers. Again, those are the stores where you would actually go purchase a product to consume off the premises or off-site, possibly usually taking it home. And then we have over 9,500 on-premise retailers. Think of those such as your bars, restaurants, or clubs where you would actually purchase and consume and be served the alcohol on their licensed premise. In Michigan, we currently have over 14,000 different codes or spirit product choices available to all of those licensees, and then in turn to all of our citizens within the Michigan. We're very proud of that number. We've increased that over the years by making kind of some changes to delisting processes or allowances for specialty products to enhance those opportunities for our businesses, our citizens, and in turn for revenue generation, not only for the state, but again, for those private business entities that are throughout Michigan. These are preliminary numbers for '24 because our financial audit has not been confirmed or released yet, but we did $1.9 billion in, this is spirit sales, and 10.5 million cases. That was for '24. How our system also works besides that those three-tier structures is we have vendors of spirits, so those are the individuals that sell the actual product to the state. They actually list the products with us. They tell us what they want that price to be. Then we actually have those 3 authorized distribution agents, which are Imperial Beverage, Great Lakes Wine and Spirits, and RNDC, that are charged to deliver that product to them and then deliver it every week to the licensee. Our ADAs do over 16,000 deliveries per week. The other number I always like to point out to individuals is they hand pick over 1 million liquor bottles in order to complete those orders for the licensee. So when I mentioned that a licensee is able to order a 1 case minimum, if you think of a standard case being like 12 750 milliliter bottles, they can actually order 1 bottle of 12 different brands. So it can be 12 literally different products. And then the ADA actually will have a pick line, and they pick those individual bottles, put it and package it into a case to go out to delivery to the licensee. Again, we're giving you some information as kind of some history and some data as to what we do and the volume of what is done through MLCC. And our distribution of total revenue, this actually just points out that we actually, I like to say instead of collected or return almost $600 million back into various parts of the state government or local communities. You can see some is distributed to the counties through the Convention Development Fund. Actually, local units of government receive over $8 million. At MLCC, any of our fees, we do not keep 100% of those fees. Matter of fact, in some cases, 100% of the fee actually is designated to go to a different revenue source. For example, our non-retail license fees and renewal fees, 100% of that goes to the Craft Beverage Council. That is the amount under MDARD. And even our license fees for our regular licenses, on-premise licenses, 55% of that fee goes back to the local community, local units of government for enforcing the code and rules. So our Auditor General audits, so we do get a financial audit done every single year. That's that bottom one there. I would like to state that our 23 financial audit actually just got released and posted, I think, yesterday, Friday. It was just done, yes. Very recently. Also want to indicate that we have not had any of the years I've been with MLCC or even anything close to that. I think I've been 14 years now with MLCC. On our annual financial audits, we have not had a finding from the Auditor General. Our performance audit, that was a performance audit on our IT systems. I think that's the one that you had a presentation on from the Auditor General. You might have some questions. That is the one that is a kind of newer. It's a couple years old now. And the data time period for that audit was October 20 through August of 22. I would like to note that that was over that pandemic time period where there was a lot of changes and uncertainties and things that none of us ever expected that we would be dealing with. So that performance or operational audit of our IT systems did have some findings, as I know you're aware of. We have done a corrective action plan to implement solutions to those findings. One of those biggest corrective action plans is our SIPS system, or SIPS Plus as we refer to it. That is our new IT system for our sales and inventory, ordering, et cetera. That is in the works right now. It's over a $10 million project. It is scheduled to go live later this year, this fall. We are targeting a go live date hopefully in October. All of the I do want to mention the replacement of our old system. So the reason why we are implementing, and very pleased that we got funding from the legislature several years ago to partner with us to develop this system, is our current system that we operate under and was the focal point of part of those IT audit and operational processes in review. It's about 50 years old. It's under a COBOL system. And there is hardly anyone around anymore that actually knows how to work with COBOL, design, change, fix. So we have been very limited over being able to do enhancements in that system. So we're really excited about our SIPS Plus system. This system, it's quite a large project. We are actually incorporating not just one or two of our internal systems, but we have a total of about 7 systems that are actually incorporating into that SIPS system. So we have our sales and inventory, we have our eQuote, which is our listing of products, we have our product registration, we have our ordering system, and we have all 3 ADAs that will be linked into that system as well. So it has taken a little bit of time to make sure we get that right. Importantly, we want to make sure we get that right and have a very successful system when we go live. Couple other key points that we outlined that we are in the process of doing under our correction action plan are our administrative orders and bulletins as those relate to our finance system. Those are all being updated to match the SIPS process and the SIPS system. Our ADA handbook is also being updated to match our SIPS requirements. That's what our 3 ADAs use as a guidebook to follow. Performing quarterly inventories, I do want to mention that there was that time period during the pandemic where we did not go in to do physical inventories. We did start those physical inventories again in 2022. We did find a way during the pandemic time period, since we could not go in and do a physical inventory, we found a way to request from the ADAs to do what we referred to as a zero inventory. So we asked the ADAs to look at any of our codes that they had zero inventory on the warehouse floor. Then we cross-referenced those with actual codes that we've had inventory on our state system. So if they showed zero, we showed we had 1 bottle, then we actually did an adjustment. We do those adjustments through our system periodically, but during that time period, because we could not go in physically, we did kind of develop and do that zero inventory count. But that is different than the quarterly inventories. And then also, we will be expanding our FTE count within our financial management division. So I think that kind of summarizes just some background information for you about what we do, the dollar amounts that we deal with, and the capacities that we deal with, and a little background about our system. So I think we'd like to open it up to questions.
Okay. Well, thank you very much for coming in. I want to start with, I believe the last time you came and presented over the Auditor General report, the new SIP system was supposed to be up and running last year. Can you talk about why it isn't and why it's about $2 million more than what was quoted for implementation, I believe, when you did the contract?
Sure, happy to do that. Again, as indicated, we want to make sure we get this correct. There are other states where they have launched new systems and they have had some significant problems with them. So we are looking very closely and monitoring that to make sure that we do not have those same issues when we go live. The other thing is we have one great opportunity from this audit to look at the positive is we have a number of audit, bless you, scenarios that we wanted to make sure we were able to incorporate into the new system and that we were very confident that we would not have any findings in the future. So again, that's something that we are I don't want to indicate that caused us to take longer, but it is something that we have incorporated to make sure. And really, it is a large project, I think larger than what was just initially expected by anyone from the vendor side or the state. We have heard from a number of our vendors that we work with. They asked us, matter of fact, just a couple weeks ago when we had a meeting with many of them. They're very nervous for our project and when we go live because of what's happened in other states. So again, it's just important that we get this right. We want to make sure that when we go live, that we can still sell alcohol. It's almost $2 billion revenue for the state of Michigan and in turn to all of those private businesses in your communities and throughout the state.
What are, if you don't mind, what are some of those issues that you're trying to troubleshoot ahead of time? I'm just curious as to.
Sure.
And while you're there, so while we're still waiting to implement, what things are you currently doing to make sure that we don't have the same result if we were to do an audit today that you had 2 years ago?
Good questions. So one of those things we are doing is we are doing those quarterly inventories. We are still doing the zero inventory concept that we talked about because we felt like that was something of importance and helped us identify adjustments that needed to be made. I also want to make sure, to be clear, I didn't mention yet, that anytime there's any bottle that is broken or maybe missing bottle, for whatever you want to refer to that as, the state is made whole. So we actually do not lose if that bottle breaks, whether that's during the process of delivery or once it's delivered and the licensee opens up the case and looks and finds out there's a problem. The licensee doesn't pay for that, nor does the state of Michigan. We are, again, doing those inventories. We actually have corrected our old system, our antiquated system. We did have some issues during this time period where we were not able to do those inventory adjustments. We buy by the full case. So because we deliver and pay for that delivery charge for the full case. So if the order comes in and we need one more bottle of Carrie's vodka, and we do not have that in our inventory, we actually buy a whole case of Carrie's vodka. We buy 12. And so those other remaining bottles are supposed to go into our inventory or into reserve. At a certain point in time, once we've done our balancing, we balance by the week right now. When we go to the new system, another enhancement is we're going to go to what we refer to as a true-up calendar or daily balancing. Right now, we balance from a week, and it takes us actually a couple weeks beyond that close of books for that week in order to actually do the balancing. And so we don't actually release those other bottles that we have held until that process is done. So there's like a delay. But we did have a problem with our system that we're happy that DTMB was able to fix. They actually fixed that later in '22, which was after this audit period was completed. But our system was not necessarily releasing when they were purchasing. It was purchasing too much and not releasing it at the time it was supposed to release it.
Thank you. I'm going to switch to Rep. Green here for a little bit.
Thank you, Mr. Chair. Just, I'm going back on that SIPS system, which still is another year out.
Nope.
When is it gonna be?
This fall,
Okay, well,
this
still,
year.
okay, so
We're
this.
going live in '25.
Live in 25, and since we're in 2025, can you explain to me why it doesn't have like an end-to-end digital tracking system, like that has real-time visibility for every bottle purchase? Like, I go to Kroger and they check out noodles, and then they know noodles are gone. How come we don't have like a real-time system?
So, well, one of the main differences is you're talking about a private business that would do their inventory versus something that crosses from the state and then also a wholesale inventory within the ADA.
No, it's just a tracking system. It's just technology. Like, since we lost a ton of alcohol, like, what was it, 62,000 bottles during COVID, why don't we have some type of live tracking system where every single bottle is? This is 2025.
Yep. Our SIP system will give us that inventory controls much better than our current system does. In SIPs, every single order will flow through Milo, which is our online ordering system. Every order will also not only have that like an order number, so we have that specific order, and then also when it's processed and delivered from the ADA and the invoice is issued, we will have another invoice number, so we can cross-reference those numbers. In our current system, we don't have those kinds of.
And I understand that, but it sounds like the SIPs is already antiquated that we're moving to. I guess I just don't understand why we're not able to track it with technology. But okay, never mind.
Yeah, I apologize if I gave some information regarding our system that's not live yet. I was trying to highlight our current system and what our new system will do. But we will definitely have more inventory controls and invoicing controls within SIPs compared to our current system that we have now.
Okay, can you go back to the slide that had where alcohol travels? So it goes to the state, there we go, and it goes to you, and then it goes to the ADAs. So does every single bottle of alcohol go through the ADAs, according to that chart?
Yes, any bottle of spirit that is purchased from one of our licensees will go through this process where actually the vendor will deliver it to the ADA warehouse.
So like, I'm just thinking like Kettle One vodka will deliver it directly to Imperial Beverage.
Correct.
And then Imperial Beverage will have it ready for the retailers to pick up. Or
Correct.
they deliver it themselves.
They will have it available on their warehouse floor to pick that product and then deliver it once it's ordered from the licensee.
So when we had all that alcohol missing, what did you guys do for oversight to find it?
We feel that the missing bottles that were outlined in the audit is not necessarily in what you would typically think of that the bottle is not there. It's actually something within our system and the timing within our system where our system did not properly identify the inventory of the bottles and balances and also did not do the adjustments or returns. One thing, if you'd ever like to go for a tour of one of the ADA warehouses, we'd love to have you. I know they would love to have you. Many of you maybe have done that possibly. One of the other aspects to the system is our licensees have the ability to refuse on delivery all or part of their order. So that one case, they can actually refuse the whole case or they can refuse part of the case. they can actually order 100 cases, and it could be out for delivery, and they could change their mind or refuse and not take that order. So that product comes back to the ADA warehouses, and it's quite a large amount of product on a daily basis that will come back. And then that product actually has to be re-put into the warehouse floor and into inventory system. And that's when I indicated we balance on a weekly basis. We don't get those adjustments necessarily that same day. We will get it within a few days, and then at the end of that week when we balance is when we do those adjustments. So at any given day, if you look at the inventory, it may not show the actual inventory if you don't take into account those other aspects of the system. One of the actual exhibits that they had in their audit is a chart that gave an example of kind of a product and its listing of dates and when we purchased it, et cetera. I'm just going to read through the column headers for you. So it has the date of the week ending, it has the balance forward, purchases, sales, inventory available, state inventory, case sales, and inventory cost. It's missing a column for orders.
Okay,
And
that-
orders are different than sales, so they're
And
not.
I guess I understand that, and that's why I'm like tracking my lunch coming in. It's a mail order, and I have a live from FedEx where my lunch is coming from. I've been from the facility back and forth, whatever. And I guess with the technology of today, with the public trust right now that we lost $1.9 billion of alcohol during COVID, do you understand why I'm questioning even if the new SIP system is going to even be effective? Because we have technology that is live tracking, and you can say this going back and forth. To me, that's insane that we don't have live tracking of alcohol, because I don't, it's hard to convince the public where it is. And because I know I want to trust the ADAs and I want to trust you, but the system clearly isn't working because we lost a bunch of alcohol, and then you had and I don't know why you didn't go check the physical security of it. Is there a reason you didn't check the physical security of it?
Are you referring to the inventory?
Yes, the missing missing alcohol.
Well, that's you're, I think,
I
asking
am
two
talking,
different
but
questions,
let's just move on, because you're
the
talking about stuff that it's kind of irrelevant to my question.
We were not able to go into, we were not essential employees, and we were not able to go in. But really, most importantly, during that pandemic time period, we were in constant communication with our ADA warehouses, making sure what their status was of COVID within those warehouses. Keep in mind that they continued to deliver to those businesses throughout that time period. There was not a disruption. But we were very cautious about who went into any of those warehouses for possible results of having an outbreak and having to have that warehouse shut down. If that were to have happened, then we could have had a halt to the alcohol delivery. We're very happy that did not happen, but part of that was within our constant communications that we were doing back and forth with them, and limiting who was in those warehouses at any given point in time.
So it was essential to sell the alcohol, but it wasn't essential to track it. Thank you. I yield.
Thank you. So actually, while you're on this slide, I kind of have a question. So it seems, if I understand this process correctly, that vendors of spirits should come in where it's at, but then it should almost be the 3 ADAs and then Michigan Liquor Control and then the 3 ADAs again, because they get dropped, the liquor gets dropped off at their warehouses, but until there's a sale, you haven't tracked any of it. Is that correct?
That is correct. So the vendor will drop or deliver, as you say, many pallets or cases of product in some cases. That is not our inventory. We do not count that. We do not, that is it's an agreement that they have. So the vendors will have a separate agreement with whichever ADA that they are working with. And that is for warehousing of that product. In some cases, it could be for promotion or sales of the product. Those are separate, independent agreements that they have. Within that delivery or pallets of products, so to speak, that comes in, as you indicated, a sale takes place, someone orders the product, one of the retail licensees, then at that point in time, we purchase the product and it becomes part of the state inventory.
So at any actual given time, we have no idea how much physical alcohol is in the state of Michigan, because it hasn't, until it's been purchased, it doesn't get tracked through our liquor control system.
It's not our inventory. We know what our inventory is, but we do not necessarily know how much a vendor actually delivers or drops, as indicate to one of those ADAs. As long as there's inventory there to fulfill the orders and fulfill the state inventory as indicated, if there is not, if we are indicating we're supposed to have that, not extra bottles from that one case that was purchased, those bottles need to be there. If those are not there, we take an adjustment or a credit on our next payment to that vendor.
Okay. I feel like I probably have 100 more questions, but they're not necessarily oversight related. They're policy related, and maybe they would be better for a policy committee meeting. I want to, if there are no further questions, I want to thank you folks for your time.
Thank you.
And keep the committee moving. But thank you,
Yeah.
and we'll probably just have some follow-up about the overall process at some
We'd be
point.
happy if you have other questions, or we'd be happy to come in and meet with any of you one-on-one. It's a very complex system, and we would be happy to come in and try and answer those questions or step you through a little more of how the process works and how we operate. And again, also extend an invitation if you ever would like to see one of the ADA warehouses, we can help with that, or you certainly can reach out to any of those ADAs directly as well.
Thank you
so
again very much.
Appreciate your time.
Thank you. Now I would like to have the Michigan Department of Health and Human Services, Megan Groen, Senior Chief Deputy Director, and Dr. George Mello, Senior Deputy Director of State Hospital Administration. If you guys could come up. Red button for the mic. We have your slide presentation. It is very lengthy. If you could do your best to move through it, we'd appreciate it.
Absolutely. We're more than happy to kind of move things along. Megan Groen, Senior Chief Deputy Director for Health Services. Excited to talk to the committee today about a lot of the work that we're doing. I cover a lot of the community-based services and a lot of the work the department is doing in that space. So part of that is avoiding inpatient psychiatric care and making sure that we have services available for those transitioning out of psychiatric care. So we will talk a little bit about how some of the things in our community-based behavioral health system move individuals. They reduce visits to the emergency department, divert individuals from ED boarding, as well as jails as well. But our mission is definitely to provide access to behavioral health care where and when people need it. We will talk a little bit about our system here and how it's designed. It's important to note that most people who access the specialty behavioral health system in the state of Michigan are down here in this prevention area. So that's going to be your lowest level of care. It is meeting people where they are. It is this level of prevention. It's staying healthy through regular checkups, accessing support through your primary care provider. And that's where most people are in their behavioral health journey that we support through MDHHS. A smaller number of people will move into this lighter blue area with early intervention and outpatient care. Those are folks who may need specialty behavioral health services. They may have a serious mental illness. They may have a serious emotional disturbance if it is a youth, or they might be an individual with developmental and intellectual disabilities. This level, people are still able to live in the community and have services delivered in their home or by a provider office close by. A smaller number of people will escalate to need residential care and kind of this intensive community-based services. So if you're looking in the green boxes, residential care might be an adult foster care, a group home type setting that's going to offer support for individuals who cannot care for themselves on their own. So you've got a lot of this intensive community-based services that, again, people are at home, as well as residential if they need that additional assistance. An even smaller number of individuals will need that inpatient hospital care. And we, Dr. Mellos will be talking later kind of about our state hospitals. And it's important to note that we also have many independent psychiatric hospitals in the state of Michigan. And we will, provide payment for that inpatient level of care. I'll go really briefly kind of through the landscape of our specialty behavioral health system. It is pretty complex in the state of Michigan. We have 10 Medicaid prepaid inpatient health plans, or you'll hear us refer to them as PIHPs. We have 46 community mental health service programs, which most people will refer to that as CMHs. And just wanted to touch briefly on the population served. We do serve all individuals experiencing a crisis, and then Medicaid individuals who are adults with serious mental illness, children with serious emotional disturbance, and the IDD population, also individuals experiencing substance use disorder. We do have a number of new initiatives that we have launched in the state of Michigan, crisis stabilization units, CCBHCs, that kind of represent a new access to care that the legislature has worked with us on opening in the last several years. Wanted to talk a little bit about the numbers and who we serve. There's a lot of information on this slide, and I'm not going to redo all of the numbers, as you can certainly follow up with us with questions. But I did want to mention that we serve over 300,000 Michiganders each year through this specialty behavioral health system. It is unique in Michigan that it is very community-based. Individuals do better when they're closer to home, when they're closer to their support network. And that's something that we do a really good job in the state of Michigan. I think we've got some of our CMH friends who will be testifying after me, and they do a really good job making sure that services are delivered in the least restrictive setting, that they're close to home, and that people can stay close to their family and the community that they're familiar with. In terms of numbers, there's those 300,000. There's also about 70,000 children on here. Over 200,000 calls, texts, and chats are received annually through our behavioral health care crisis lines and peer warm supports. For perspective, this is more calls and texts than there are people in the entire city of Lansing and East Lansing combined, yet each caller is given individual attention and support based on their unique situation and needs. I'll talk briefly about some of what these current behavioral health initiatives that through the support of the legislature, both through legislation as well as state budget efforts, have really expanded some of the transitions that we have, and really working to make sure people can stay close to home, and that build this continuum of care so people can have the right level of care at the right time. Too often you hear about people who are maybe stuck in emergency rooms, you hear of people who are maybe ready to be discharged from inpatient care but don't have somewhere to go. And we'll talk a little bit about some of the things that we have stood up to address that in the state of Michigan. The first one is crisis stabilization units. This was something that was a public act that the legislature passed in 2020 and authorized the creation of these CSUs as alternatives to hospitalization. So the goal is for everyone in our state to have somebody to call, somebody to respond, and a safe place to go when they're in crisis. We talked a little bit about behavioral health hotlines and things like that you call. You have somebody to respond. That's a mobile crisis unit that we have and we'll talk about through our CMH system as well as CCBHCs. The CSUs is really somewhere people can go and make sure that people have that access to care. It's only there for 72 hours. but it's something that, individuals can go, it can have that immediate access to crisis services. And you'll see folks there that kind of reduces people going to the emergency room, improves jail diversion, and allows for better utilization of inpatient psychiatric hospital beds. So these programs aren't necessarily intended to replace ongoing treatment. They're meant to offer fast and easy access to individuals when they need it most. This is our map. What you will see from here is that we have 2 CSUs that are currently open in Wayne County and Kent County, and those have seen nearly 2,900 people this current year. I was fortunate enough to be there just a couple weeks ago at Trinity and Network 180, who have a CSU in Kent County. They shared with me that 80% of their patients that showed up at that door needing an inpatient level of care were able to be stabilized and then connected with community-based supports, so they did not escalate to inpatient care. They were able to then be stabilized in that environment and then be brought back into the community and connected with those resources through Network 180, which is our CMH in Kent County, and able to be served in that space. So they are already avoiding costly inpatient stays and preserving those inpatient beds for individuals who truly need them. I wanted to talk a little bit about transition services, which is something that we have spent a lot of time at the department working on. These are step up and step down facilities. One way to think about this is if you go into the hospital and you have, some type of surgery, a lot of times you're not ready to go exactly home, right? Like maybe you have a step down facility or something like that. Behavioral health care can be exactly the same way. So a lot of what these services are is somebody who's maybe at that inpatient hospital and not quite ready to go home, but needs those step down services closer to their family, closer to the community. They can get out more and do those pieces. In December of 2023, we established PRTF as a Medicaid benefit. This is specifically for children. We did stand this up originally as a general fund benefit, and we're able to kind of work with providers and bring them online to serve a lot of youth who were waiting in emergency rooms, who were at an inpatient and not quite ready to go home. And so what it has really done, can look at some numbers here. In some of these admissions, you can see it's not the biggest program we have at the state, but it's one of the most impactful because you see, especially with children, a lot of people who have gone from placement to placement to placement. And at a PRTF, they're able to, it's a small setting, only a couple kids and staff are there and really able to get the attention that they need so that they can transition to a community-based setting and stay there. And that's something, we have wonderful stories about youth who are now back in high school, participating in extracurricular activities, who are reunited with families, and that's something that we're really excited about. We also have ICTS, which is our adult program. Unfortunately, there's not a Medicaid benefit available for this, so that is done with general fund. It is something that now that we have some experience doing this, and quite frankly, it being very successful from a very early standpoint, that we are looking at a new Medicaid benefit, which we will again kind of stand up with some general fund dollars that were appropriated in the last budget to do something specifically for individuals with developmental disabilities. We're seeing a lot of folks who have IDD as well as behavioral health issues that need a transition service, that need somewhere to go. A PRTF might not be the right setting for them because they need specialized staff. They also might need longer than the 90 days that you're going to be in a PRTF. And so we're working on standing that up right now. It is something that we are really excited about, and I look forward to keeping the committee updated on that if you are interested, but something that we really want to make sure we see a gap in the system, again, for some of these transition populations. I'll talk really briefly about CCBHCs. This is a demonstration that we stood up a few years ago in the state of Michigan. What it is nonprofit or local government agencies, and they're providing comprehensive outpatient behavioral health services. What's great about a CCBHC is they're going to serve anyone, regardless of their ability to pay, regardless of their geography and where they live in the state, as well as regardless of their diagnosis. So if you don't know if you have a serious mental illness or serious emotional disturbance, or you just know you need help, you can go to a CCBHC, and it is a Medicaid-funded benefit. CCBHCs are really instrumental in their crisis response. There's 24/7 crisis services, so this is immediate around-the-clock access, something that we saw as, well, some of this is available through our CMH system, something that we saw as a gap in coverage, and really wanted to reduce that reliance on emergency rooms and inpatient care. I will not go through all of the numbers on this slide, and it's a little hard to read, but just wanted to highlight kind of the community impact that we have seen just in the last couple years in our CCBHCs, who are serving about 150,000 individuals right now. This includes several thousand veterans, something that is a core service of CCBHCs, that they have to be able to be specially trained to serve active duty military as well as veterans, and something that, you know, we saw as another gap in our system that we wanted to make sure that we addressed through CCBHCs. Another thing about CCBHCs is a lot of the providers that became a CCBHC were only serving that specialty behavioral health system, and really allowed them to expand into mild and moderate services as well. So again, they can serve anyone who walks in the door, kind of regardless of that diagnosis and what they need. We're seeing a lot of people taking advantage to services that were never available to them before, people being served in different counties than where they live, and people who, you know, this is traditionally a Medicaid system, and you do not have to be on Medicaid to be served there. So we already did this slide, but I wanted to kind of pull it back up as I transition over to Dr. Mellos, who can really tell you about state psychiatric hospitals and kind of that inpatient level of care.
Right. So I'm going to go back to that slide for a moment here, and where we are is in the upper right-hand corner, the inpatient hospital care. And we are just a tiny piece of that upper right-hand corner. Most of that is the inpatient hospital psychiatric care, private sector beds at facilities like Cedar Creek, for example, which is fairly local. We're the state hospitals. We have about 660 operational beds, just a tiny sliver of that upper right-hand corner. The state hospitals in Michigan, most of you are aware, we have a new hospital replacing the old one built in 1914, opened up in 2021, Caro Psychiatric Hospital up in Tuscola County. About 96 patients present on average. They have 100 beds. Kalamazoo Psychiatric Hospital in Kalamazoo, the one of the oldest in the country, actually. Parts of the building were built in the 1850s. A census of about 115. And at Walter Reuther is a combination of adult and children's services. The adult side has about 100 patients, and the kids side, we can operate about 25 at this time. And that is in Westland, Michigan. And then finally, the Center for Forensic Psychiatry, on average about 240 patients, is in Saline, Michigan, a very specialized population, the forensic process population. Admission process to state hospitals is much different than the private sector. Private sector, you have a behavioral health issue, you go to an ER, you're assessed, you're deemed, for example, suicidal, and your insurance approves you to go to a local inpatient psychiatric facility like Cedar Creek for 7 to 10 days of treatment on average. Our facilities are much different. We treat people, and our mission is to treat people with high and severe behaviors, the highest and severest behaviors of individuals with serious mental illness and whose behaviors stem largely from psychosis spectrum disorders, mood spectrum disorders. And the process to get a person into the facility, there are two different types. There's the forensic process and the probate process. Forensic process comes out of Chapter 10 of the Michigan Mental Health Code, and there is a crime is committed by someone who is who looks like the crime may have stemmed from or been related to serious mental illness. A prosecutor would ask for an evaluation at the forensic center of the possibility that the person may have been incompetent to stand trial because of the mental illness. And if a judge agrees with our opinion about that matter, then the person is ordered into the forensic center for competency restoration. The probate process patients, on the other hand, Chapter 4 of the Michigan Mental Health Code, adults are either voluntary or involuntary. Youth are always voluntary. The person is opined by a physician to have serious mental illness that might result in death of the patient or someone else. So there's a petition and certificate that is processed, and then typically the patients again go to a local private sector hospital, psychiatric hospital. On the other hand, if a person has failed multiple private sector psychiatric hospitalizations and other community-based treatments, then that person is authorized by community mental health to come to a state hospital. And again, youth, very similar, except we do not commit or petition youth in the state of Michigan. The admissions are all voluntary. So all of our admissions must be authorized by community mental health prior to admission. Then the hospital staff at the facility can decline a probate process admission if it's not medically appropriate. The forensic process admissions, on the other hand, are court-ordered into the facilities and cannot be declined. Our wait lists as of today, we only have 4 people waiting today for probate process admissions. Forensic process is about 269, which is better than most of the other states in the United States. And pediatric admission wait list is 25. And the forensic process evaluation wait list is at about 480. And those are people who have been ordered to the forensic center for assessment of competency, not necessarily yet admission. We have reduced our evaluation wait list pretty substantially over the past year and a half, and through triaging evaluations and then also setting up video conference evaluations right from the jail, as opposed to having people transported to the forensic center. The number of defendants referred for IST admission to our facilities has dramatically increased. Annually in 2018, it was about 141. It's up to 740. It's just a dramatic increase. And we have reduced the length of stay for people at the end of forensic process admissions, the not guilty by reason of insanity and incompetent to stand trial non-restorable individuals. We've reduced our length of stay from 90 months in 2015 down to 40 months, which has allowed us to increase throughput in the adult facilities pretty dramatically. You can see, like in 2024, we admitted 626 and discharged 630. We like to see that ratio right around 1, and that demonstrates that we were able to admit and discharge a total of 1,200 people, adults. So we are in the process of transitioning the Walter Reuther complex to a new state psychiatric hospital in Northville. where we will have 264 beds, 192 adult beds, and 72 pediatric beds. Because we are increasing the number of beds totally by 54 and occupying a new physical plant, we have proposed an investment of $15.2 million to support recruitment and staffing of the additional personnel that we'll need to manage that facility. It's about 145 FTEs.
I appreciate it.
All right.
If we could just go into questions, because I think
Yeah.
the rest of it is about this hospital specifically.
yeah.
And so I'm going to start with the first one. So what it kind of sounds like here is that the state manages some psychiatric beds, but you're saying most of them are not state responsibility.
That is correct. We operate just 660 state psychiatric, and they're the state psychiatric beds. They are unlicensed beds, unlike the private sector beds that are all licensed, and we serve people with the most high and severe behaviors that cannot be served in the private sector.
And looking at the charts that you had, most of those folks that are on a waiting list, it looked like they seem to be on the forensic side of things. So these are criminal cases that are waiting to be determined if they are competent for trial versus need hospitalization. What we're hearing from our communities are that there are not enough psychiatric beds. And so where does the state play into that comment? I mean, we're hearing it from hospitals, we're hearing it from our sheriffs, we're hearing it from people everywhere. So if folks they don't have insurance, they're homeless, they need mental help, why is that not the state's role? Why is that please.
At first, I think I want to say that Megan and I both share deep concern about that population, and I'm going to let you go ahead and describe where we're at with that.
So, I mean, in terms of like an actual inpatient psychiatric evaluation, the community mental health system does do that, right? So we work with hospitals and sheriffs all the time, and I think we have a couple CMHs that'll testify as well, but they do go in and do an evaluation. We see a variety of different things. Sometimes people do need an inpatient level of care. Sometimes they have other needs, right? They might have social determinants of health needs, they might have housing needs, and we do try to make sure that they're, through that CMH system, connected with the right level of care and all of the right resources, right? There might not only be one problem, right? You might need housing and you might need some outpatient care. To the extent that people need inpatient and they are covered by Medicaid, we do authorize payment for that, and that is something that does occur. In terms of, having what we also see in terms of inpatient beds is a lot of times individuals being ready to go home, but not actually being able to go back directly to home, right? Maybe parents aren't ready to serve them at that level of need. Maybe they need a transition. And so that's why we focused so much on these transition pieces, knowing that that was something that the state had the ability, the support of the legislature, and the funding appropriated to do. And so that's where we focused a lot of our efforts for a couple different reasons. It diverts people. It also frees up those inpatient psychiatric beds for those who need them by making sure that those who no longer do are able to have a transition out of them. So we have focused a lot of our efforts on that piece.
So for us moving forward, what kind of policy suggestions would you have that would help make sure that folks have access to these beds? I mean, Caro is in my community, right? That was supposed to be a much larger facility, and it was more than halved in what it was supposed to be for new construction. So, but it kind of sounds like you don't feel like those were the appropriate beds for most of the people we're talking about. So I guess I'm just kind of curious as to what your policy suggestions are. So
the population, I believe that we're talking about, there are multiple variables that go into why they are in the emergency department. You know, there's homelessness, substance use, intellectual disability, and in addition to mental illness. And so we have to look at where is the weight of the variable that is causing this person's issue. If it is certainly serious mental illness and the behaviors are very severe, then they are appropriate for a state hospital bed. So in terms of policy, we need to look at if the issue stems from substance use, what do we need to do to make sure that they get leveled into the right care from the ER and rapidly? And then an issue that's really important to me in particular is people with intellectual disabilities who end up in emergency departments. I do believe that we have an opportunity for pretty substantial policy change in our state in regard to making sure people whose behaviors stem from intellectual disability largely get to the right place quickly instead of being in ERs or stuck in psychiatric beds where they should not be for a really long time because there's nowhere else for them to go, as Megan was saying earlier.
So do you think then, as we've moved, the state has moved out of it, that there was a centralized hospital system, and we kind of divested from that from the 80s on to where we currently are, to this more community-based care. Do you feel like that's working?
From my perspective, community is where people should be. People with mental illness, intellectual disabilities, as much as is possible, should be in their homes with their families and their communities. And that was the goal of deinstitutionalization. Did we overshoot that a little bit 40 years ago? I think that may be the case. And like I said, there are policy opportunities here that I think we need to look at. Megan, do you have any thoughts about that?
I agree with everything you said, Dr. Mellos. I will say we will need support for some of those. It's hard. You don't just stand things up overnight, right? And so when we talked about specifically the Medicaid benefit for the IDD population, which is something that we have heard from our hospitals and others, right, that is something we need to address. I'm also happy we started with a different population first, right, because there are different challenges. And so I think we feel well-positioned to do that and start looking and standing up that policy with the general fund appropriation that we have. But at some point, if we want to make that a Medicaid benefit, we'll need to put it in the state plan and we'll need an appropriation.
And then kind of my final question, I don't see any others. So do you have oversight of is it MDHHS's responsibility to have oversight of non-state hospitals? Like who makes sure that the appropriate care is being received at the appropriate levels for these private facilities?
That's largely under, the facilities are accredited by Joint Commission, certainly. And so the accreditation is largely through Joint Commission. And then they are licensed beds, so Laura has purview also.
So if it's through Joint Commission, then you have to do certificate of need for beds and all, that's the process to build a new facility. So we heard last week that Michigan has like 5 beds per 100,000 people, and we should have 40 to 50 beds per 100,000 people. Is this a Joint Commission issue, or is this a nobody wants to build these hospitals because they don't get reimbursed issue? What?
Are we talking private sector beds?
It was just beds in Michigan.
I mean, I think an appropriate follow-up might be, we do have CON and psychiatric beds, so we can get you a map and the chart of all the numbers of where the beds are in Michigan on that private side, if that is helpful for you. In terms of oversight, we don't necessarily have oversight over that, right? But that is done through the CON process, so we can certainly demonstrate where those beds exist and those types of things, if that would be helpful information for you.
Thank you very much. I don't see any other questions. Thank you both for your time, and we do appreciate it. Next, we have Ric Compton, CEO of Riverwood Center in Berrien County, and Chris Pinter, CEO of Arenac Behavioral Health. They are here on behalf of Community Mental Health Association of Michigan. Gentlemen, please have a seat, push the red button, and we have 17 minutes until we have to gavel out. So appreciate you being here.
Good afternoon. My name is Ric Compton, and I am the CEO of Riverwood Center, Berrien Mental Health Authority, the Community Mental Health Center and Certified Community Behavioral Health Clinic in beautiful Southwest Michigan, Berrien County. Vice Chair Brad Paquette represents much of the area that we provide behavioral health services and services to people with intellectual and developmental disabilities. Today, I will be addressing the challenges with inpatient psychiatric services, including bed availability, challenging patients or consumers, care across the behavioral health continuum, and Medicaid funding challenges with CMHs in the public mental health system in Michigan. I believe that I can provide a unique perspective on these issues because of my background. I have truly seen the issue from multiple sides, both as a payer, provider, and across several states in the Midwest. Moreover, my family is also a consumer of behavioral health services. My late brother died, and he was a consumer all of his life. In 1983, my father was shot by a mental health consumer. I started my career at CMH in the Upper Peninsula. I worked for a large Medicaid managed care insurance provider, Options in Nebraska. I was also the Medicaid director for the state of Nebraska for 3 years. I was the director of behavioral health services for a Catholic hospital system in the Fox Valley of Wisconsin for 7 years. The system had 3 psychiatric inpatient units, including 2 adult and 1 children's units. I was the CEO of the State Psychiatric Hospital Human Services Center in Yankton, South Dakota, with over 300 beds in adolescent, adults, and geriatrics. And finally, the last 10 years, I've been in Southwest Michigan as the CEO of Riverwood. With my 35-plus years of being in the behavioral health world has taught me a few things. The issues are complex for behavioral health. Dedicated and wonderful people work on all parts of the behavioral health care continuum, from outpatient to inpatient and all the services in between. Huge advances in medication and evidence-based practices have helped provide impressive outcomes and improve lives for so many people living with the challenges of mental health over the past 20 to 30 years. However, the stigma of mental illness, substance use disorders, and people living with intellectual and developmental disability persists today. I used to work with a psychiatrist by the name of Ivan Walks, and he said that the brain is part of every medical textbook he ever saw. Simply put, you cannot have good health without good mental health. So let me tell you a little bit about Berrien County, and I'll do this really briefly. We have about 152,000 people. About 28,000 live on Medicaid, 11,000 are in Healthy Michigan. Riverwood Center, our CMH, employs about 186 staff. We have 6 locations. Our outpatient services are in Benton Harbor, St. Joe, and Niles. We employ 3 psychiatrists, including a child and adolescent psychiatrist, and 5 nurse practitioners. We also have 16 outpatient therapists and 8 SUD therapists. In 2024, Riverwood had 276,000 encounters. When I say Riverwood, I mean both our internal and external providers. So what's not known about CMHs is that we contract, over 2/3 of our budget is contracted with outside providers. Riverwood Center provided over 45,000 CCBHC visits, and we saw 5,700 unduplicated consumers. So what has Riverwood done to provide crisis services to help create care alternatives to hospital inpatient care? We provide 24/7 crisis line. We provide a behavioral health urgent care services. We provide mobile crisis with a master's clinician and peer for both adults and kids. And we have a hospital pre-screening and assessment process with a master's level clinician providing screening 24/7. And then we also have a hospital liaison that works on hospital discharge. Riverwood meets monthly or more with all of our local hospitals, Corwell Lakeland, SUD providers, health department, sheriff's office, and many other community providers to discuss challenges and work toward solutions. The psychiatric bed challenge. Michigan's a big state. Challenges are vary from the UP to Lansing to Detroit. Inpatient care is not a standalone event, but needs to be part of a care continuum, with each transition an important part of the recovery process. Discharge care and placement are often a big barrier to inpatient admission. Consumers with active substance use disorders present unique challenges to that system. Inpatient psychiatric hospitals are not like hotels, not just number of beds. Admissions depend on available staff, psychiatrists, patient milieu, the severity, the gender of those patients, and the alternative services that are available. CMHs review admissions both for Medicaid and general fund consumers for inpatient psychiatric care. With master's level commissions, we use something called the MCG process across all CMHs across the state. Southwest Michigan challenges are not due to a lack of psychiatric beds. Hospitals do not often want to take the most severe cases. People with aggressive behaviors, both people with mental illness and or IDD. Inpatient units need to share the burden of the most severe cases with psychiatric intensive care units. Step-down placements for physically aggressive consumers is a major barrier to discharge. Lack of providers willing and able to take difficult consumers. And the state hospitals have reduced the current bed capacity and have changed admission criteria for people with IDD. I know Dr. Mello's talked about that, and state hospitals aren't the perfect place for folks with IDD. The problem is there has not been a supplemental care alternative. Berrien County Riverwood inpatient numbers. I won't go over all these numbers, but say we do pre-screenings on roughly 1,000 or more a year. We have about half of those reach inpatient, and their average length of stay is between 6 and 8 days. We do follow our stats, something with the Michigan mission-based performance indicator system. It's a state-recorded quality system for all CMHs. So to the issue of inpatient screening and the people are languishing in the ER, the 3-hour review is one thing that we keep track of. In 2024, we met that 3-hour review or less 100% of the time. In 22 and 23, we met it 99% of the time. 7-day discharge, outpatient appointment follow-up at Riverwood, again, helping people get out of the hospital. And between 22 and 24, we were at 95 to 99%.
Can I stop you for just a second? The 7-day discharge, can you explain what that is?
Yeah, so we want somebody who's been discharged from an inpatient facility, we want to get them to an outpatient therapist or a psychiatrist within 7 days. That's the gold standard for mental health. Possible steps towards improvement. No one solution. There is no one solution. This is a big problem. Resurrect the Michigan Psychiatric Care Improvement Project, the 2-part crisis system. Crisis and access line, 988. It's not referring right now to CMHs. It's almost a standalone system. It needs to be looked at. Psychiatric bed registration. That was part of the My Care project. That's now defunct. Something needs to be brought back to replace that so you can know how many beds are out there. Crisis stabilization unit. The folks from MDHHS spoke about that. Those need to be funded appropriately, and we need more of them. Mobile crisis. Again, the 37 CCBHCs in the state provide that, although it's going to be a challenge for people living in the rural communities, especially in the northern part of Michigan, because the criteria is too difficult for them to establish. And then our 1115 waiver, which is what the Center for Medicare and Medicaid Services require for the managed care system. We need to look at IMD exclusion, which is the Institute for Mental Disease, which is a freestanding hospital. That needs to be the PRTF, which they spoke about, and then also children's therapeutic foster care. Increase the availability of step-down placement, particularly, again, for aggressive patients. Increase and bolster bed available through the Michigan's Medicaid Community Transition Services. Right now, it's mostly on the west part of the state with the Beacon and Hope Network. We need more. Remove bureaucratic challenges to place difficult consumers. Need for locked units for difficult and aggressive consumers. And inpatient units need to share the burden of the most severe cases with psychiatric intensive care units. Finally, the MyHIN, or the Michigan Health Information Network Shared Services, a health information exchange network, needs to be expanded across the state to include mental health and substance use disorder care for inpatient care and supplemental services. We need to protect staff and consumers alike. Not all violent behavior is caused or result of a person's mental illness. The SAVE Act needs to be expanded to behavioral health. Future challenges. State-appropriated money has not reached the CMHs or PHPs. Over $200 million less than appropriated by the Michigan legislature over the past years, although we have heard there's a rate rebasing. We heard that on Friday, so we're hoping that those hours do come to us. COVID and the public health emergency reset the delivery of behavioral health care. There was a lot of pent-up need and demand. There was a great deal of medical inflation, but unfortunately, expenses went up and revenue did not increase at the same rate or went down since 2023 to the CMH PHP system. And the PHP rebid in 2026 will cause incredible disruption in the system and lead to greater wait times and less coordination of services for inpatient services. Finally, everyone needs to collaborate in behavioral health to improve the delivery of care.
So I don't know how much time I have, Mr. Chair. I'm trying to stay on. Okay. I'm Chris Pinter with Arenac Community Mental Health. I've been involved in community mental health in one way or the other as a student, a case manager, a therapist, a supervisor, a manager, or a CEO for 38 years. And I've been fortunate. I've been able to work at Genesee County, where I was born. I've worked in Saginaw County. I've worked in Bay and Arenac counties is where I'm at now. I wanted to just touch base quickly on, there were some discussions I know in a previous hearing about the psychiatric admission process and the pre-screening process that's done at the county level. And I just wanted the committee to understand that that's essentially, prior to the 90s, as Dr. Mellos mentioned, we used to have a significant number of state beds. In the 50s, we had 29,000 people in state facilities in Michigan in the 50s. We had 40 hospitals. We're now down to 600 beds total. So where do those, our population has decreased a little bit compared to some of the other states, and we've lost our congressional representatives, but in general, our population has stayed pretty stable. So where have those 28,400 people, where do they get served now, where they didn't in 1950? They get served in the community mental health system. That's a system the counties provide a backbone system to people who formerly were served by the state. The state transferred those responsibilities under law to the counties. And so we've taken over that responsibility and built out community services. So one of the things that we struggle with psychiatric admissions is the fact that we essentially serve as the 911 for anybody in the public who needs to go to a hospital. So think of how it was prior to 911. If your house was on fire, you called your township. Well, geez, they're already out. Maybe you could call Bay City. Maybe Bay City could send a truck. No, you have central dispatch. Central dispatch can identify state police, sheriff, municipal police to respond to an emergency right away. That's essentially what the pre-screening process was set up at the county level, so that we could identify where a bed was, where we could get somebody admitted to the hospital. And that's essentially why the pre-screening thing was put in place. So think of it as 911 for anybody in the community, not just the people who got insurance, not just the people that the private hospitals want to serve, but everybody, anybody who comes into this community that needs psychiatric care. So that serves as the central place to get them connected up to care. And we've been supported over the years with the Certificate of Need Commission. They've added a number of beds, statewide inpatient beds. So we actually have more inpatient beds now than we did 5 years ago. Unfortunately, the occupancy rate has went down. So even though we've added more beds to the private system, people aren't getting in any easier. We have a little bit better luck in Bay County because I'm not only, as McLaren Bay Region, my landlord, not only is my office above the psychiatric unit, so there's times when I have a pretty good idea of what's going on down there just from the banging on the walls I can hear. We also provide all of our services after hours out of their emergency room. So my pre-screening staff are shoulder to shoulder with the ER docs in Bay County. So we have about an 80% occupancy rate on the McLaren Bay region in Bay County. The state average is about 65%. So we're able to get adults in. And I think it's because we have that relationship with the hospital. In fact, they ask us to do their pre-screenings for their non-mental health patients. So we must not be as slow and as cumbersome and as burdensome as some folks, at least in Bay County we're not, because they actually pay us to do all their private screenings for them. I think the other thing I want to point out is, and this is what Rick mentioned and Dr. Mellos mentioned, at some point, there's a protective custody need for people. People come in either through the probate courts or the sheriff or a peace officer brings them in or their family brings them in. And there's times when their level of disability or their ability to cope with life, it's not always things that can just be pointed to as, well, we'll treat that with medication, we'll put those in, we'll get them in group therapy, 2 weeks they'll be ready to go, we can get them back out. We have some people whose behaviors and situations are so intense that they need a protective custody. And that's not what the department necessarily wants to hear, because they don't want to use their limited beds for protective custody. The inpatient units, the privates, don't want to do protective custody. They use the Medicare DRGs. They want somebody in for 7 to 10 days. They want them out. And if we come back and say, if he discharges, he's going to kill somebody. Well, he can't go to jail until he's actually hurt somebody, right? I can't lock him up. I can put him in my crisis residential that I've developed in the last few years to help take the edge off inpatient beds. But in general, we have a public obligation to these patients that the psychiatric hospitals don't have. We have to get them safe somewhere. We have to get them somewhere to where their health and safety and their family's protected. If that doesn't happen, their family shows up at my next board meeting, which I have 6 committee meetings a month, just like you guys even more, and they'll demand that Chris be fired. So that's why I'm accountable to these parents and these families, because I want their loved ones to be safe, and I may run into them at Cruciacs next week and hear about it in the men's room about I didn't get them care. So that's where our accountability comes in. The state doesn't have that level of accountability. They don't have that. They don't have people coming to, I mean, I'm sure there are people who see them in Lansing. In general, people in Arenac County don't go to the state with their concerns. They go to my commission in Arenac County, and they say, what is the mental health program even doing for us? And they say, Chris, what are you doing for them? And I say, well, I've added a mobile response team. I've added a crisis residential. I have sent my personal care CLS staff into McLaren on all waking and night shift hours for 7-10 days at a hand to keep people safe, because we can't get a bed, so we're boarding them in ER. They feel a little better if my people are in there too. I've shown some skin of the game, and we're trying to keep everybody safe. So I think it's important for the committee to understand the real issue on this is that at the end of the day, the private hospitals don't have the same obligations to the public that we have as a county agency. They don't have the same direct accountability to their elected representatives, and they don't have the same moral accountability. It's an open market. If we have people that we certify for the hospital, the department says, boy, that's protective custody, Chris. We've only got 600 beds. We have quit doing protective custody, 40 years ago. The hospital says, I don't care how much you give me, I'm not admitting him because he might hurt somebody, and we don't want that cost benefit on us. And I say, great, as long as he's in the community, somebody's going to get hurt. So I got to get him somewhere before my sheriff comes in and puts me in jail for the guy ended up in jail because we didn't get him a hospital bed. So that's
Chris, I'm sorry,
that's the
I
key.
have to cut you off. I apologize. I hope that you folks will make yourself available as we continue this conversation, and I really appreciate your time. Again, I apologize. There being no further business before the committee will stand adjourned.